Good morning, everyone. It's Lana Comstock with the Iowa Healthcare Collaborative. Welcome to our webinar today. We're super excited that we were able to give you this opportunity to spend with Nancy Wild from the Iowa Department of Public Health. Many of you already know Nancy and you know what a resource she is for us. So without further ado, let's go ahead and get started. Nancy, welcome.
Thank you, everyone, and happy Halloween. I made my title today, It Isn't Really Scary. NHSN is not, although I'm sure that when you're new and starting out, it feels that way. So I was going to go on to the first slide here. Since a lot of you that are on this call and that are signing up to this are fairly new, I just wanted to give a real quick update or some background on NHSN. NHSN started it as the CDC's National Healthcare Safety Network. It was started off of, there was a couple of different systems that they combined. One was for end-stage renal failure program, and then one was an old NIST program that allowed hospitals to track healthcare-associated infections. And this kind of combined and merged those two systems and really started in the early 2000s, about 2005, I think, is when it was first started being used. It's changed a lot over the years. It is the most widely used tracking system for healthcare-associated infections, and there's several different components that you can use with NHSN. The ones most common are the patient safety component, and then that's broken into healthcare-associated or device-associated, procedure-associated. The medication associated, which I don't know that anybody is really participating in, the MDRO and CDI, and the vaccination for the healthcare patient, the patient data for that. And then you've got the healthcare worker safety component, which is where you're documenting your healthcare worker immunizations for influenza. So why do we use NHSN? Because I get these questions a lot for those of you that are out there, especially for critical access hospitals. Why do I need to be reporting? When I first started working in infection prevention statewide, we had a couple of different systems. IHC had a system. IDPH was starting to use NHSN. Other hospitals had some things that they were doing to record their data. This gives us an opportunity for us to all be in one place, use a consistent criteria and definitions, and record the data so it can be used for reports. We do have the statewide steering committee that has sanctioned the use of NHSN for facilities. IHC with the HIN is using this. There are some QIO projects that are using NHSN. They've really transitioned that now towards more of their long-term care effort. But the biggest advantage to this is that it uses standardized definitions. So if I'm calling something a UTI, then you guys should be calling the same thing as a UTI. So it makes that, kind of levels out that playing field a little bit. But the best thing is that it does give you the ability to do some data analysis. And I don't know how many of you saw this recently. This was every year CDC releases an annual report based on NHSN data. This was just sent out, and I do have the link here in another couple of slides to where you can access this. It's part of the patient safety atlas that's been out there that you've had access to for quite a while, but they've changed the transition, so it looks a little bit different this year. So you'll notice that this is for the data for the year 2016. So there is a little bit of a lag before this comes out, and I understand that, and that gets to be a little bit of a challenge, but the information is really good, and it helps us to determine where we need to be focusing our attention. And I know that IHC uses it the same way, and CDC uses it because as they're coming up with grants and funding, they want to know where they need to be putting their money. So this first slide here on the data, this is showing you that the CLABSI rate for Iowa is actually really good. So it's 37% of it below baseline, which means that our SIR is going to be 63%, or 63.63. the national SIR is obviously going to be at 1. We did have, it also says here that the Iowa hospitals, when you look at this, had a significant decrease in the CLABSI rate between 2015 and 2016. And if you remember back to 2000, for those of you who are doing this, in 2015 they did the rebaseline. So we knew that those numbers were going to go up, so that the annual SIR was up a little bit. But this shows that we're continuing to make progress on our CLABSI, because this is using the 2015 baseline. There was only 23 hospitals in the state that had enough data to calculate a SIR, which is not unusual, and we're one of those states that has fewer acute care hospitals, and we know that that number is kind of small. They do suppress things so the smaller hospitals aren't showing up their data in this system. CODIs, you can see, we unfortunately aren't any better, but we're also not any worse. We haven't changed from the national baseline. We really haven't had any significant decrease. Now, keep in mind that this is from 2016 data, so we'll also be able to continue to monitor for 2017. The MRSA bacteremia, I think this is a wonderful slide for Iowa, because it shows that we are down 41% from the national baseline, so that is amazing. That's only 16 hospitals reporting, but those are going to be the bigger hospitals. But it does tell me that we are making progress on this goal. We didn't see a lot of change between 2016 and 2015. C. diff we're also doing really well with, even though our numbers are not where we want them to be with C. diff. The hospitals that are reporting, and that's 34, which is the biggest number that we have of any of the types of infections that are being monitored. We are still well below the national baseline. This is the area. Surgical site infections is one of the areas that we need to continue to focus on, and I know that a lot of you are already doing that and looking at this quite a bit. But for our hysterectomies, we're 30% above the national baseline. So, and for colon surgeries, it's 6% above the national baseline. And if you go over to the colon surgeries, 14% of the hospitals, which is only going to be, I think, what, 2 hospitals, had enough. They were significantly higher. So we've got a couple hospitals in the state that have higher rates for colon surgery. So that's probably accounting for most of the increase in that area. So I just wanted to give you a little bit, because I know that some of you wonder what's being done. Why am I putting my data in here? It does get used. And even though that there's a little bit of a delay, it's getting used by CDC to generate these kinds of reports to determine where they're putting their emphasis. It's being used by IDPH as we move forward in the HAI steering committee, and also you've got the HIN who's looking at this and trying to help you implement quality improvement programs. So it is something that you're going to continue to hear about. So I just wanted to start out here and give you a little bit of a background for those of you that are just getting started in NHSN. I think most of you have already been into the system, but you can set up your facility in a variety of ways and give information. One of the main ways that you're setting up your facility is adding locations. So the location tab, if you go down on that blue column over onto the left, there's a facility tab. You open that up and you've got multiple areas that you can go into. One of those is add a location. If you go into that and choose find, it will show you all the locations that are mapped for your facility. This is important because if you do have, if you're critical access, often it just is going to say med surg, and that's fine. But if you have multiple areas, CMS has been asking for you to map each one of those separately. So that would give you the opportunity to see how your facility is set up. Now, if you're remodeling and the name of your unit changes, you can go in and you can modify that location. You can make a location inactive. So if you had an area that you were putting your swing beds and that is no longer effective, you could go in and close West Wing if you needed to, and you can add locations as needed. So if you go in and click Find, this is what you're going to see. Well, you may not see this many units. This is a test facility that I have access to, and it gives me the opportunity. You can go in here and this will list out the types of facilities, the name of the unit that you have set up, and then how it's described on the CDC description. And that's really important that you know that, because that tells them if it's a critical care unit or if it's a medical unit of some sort. Now, on the first column there where it says your code and your label, CDC doesn't care what you put in those areas. Those need to apply to you and make sense to you. So a lot of times it will just be med-surg, and you can do that. Sometimes you'll put West Wing. It doesn't make any difference what you do that. Where it really gets into be an issue is the CDC description and the CDC code. So you do need to code those out correctly so that it would be a med-surg ward or a critical care, whether it was surgical or cardiac or trauma, that type of a thing. When I saw the list of attendees, I know that there's a lot of you that are fairly new to this system, and maybe you don't even have access to NHSN. So if you do have somebody in your facility that you need to be adding, how you get started in NHSN if you don't have access is somebody can go into that system. It's under Add a User. If you go in the blue column there, it says Users. You can add or find. And the facility administrator goes in. There's very little information that is required. You add a username, which I tend to just start with something real simple. I'm not that creative, so I use first initial and last name as my username, but you can do anything that you want to do. You do need to make sure that you enter a correct email address in that area. Now, this becomes really important if the current IP is leaving and a new person is coming in. If at all possible, you can get that done before that transition. It makes it a much easier process to transition over to the new IP. If that doesn't happen, just call me and I can tell you what needs to go in. But all you would need to do then is to send an email on hospital letterhead from somebody in the C-suite to NHSN saying that Nancy has left the facility and Susie is taking over the role as facility administrator, and here's her ID or her email address. Probably one of the more important things on this screen here, and I've been out to some of the hospitals when we look at the users, once somebody gets added onto the users, it is important that you go in and disconnect or disable somebody if they're leaving your facility. So there's a question here on what if you want 2 people? I encourage every facility to have a backup plan for somebody else with access to the system. And you can go in and you can add as many people as users as you want in your facility. So I usually encourage, I think 2 is pretty standard. There's usually an IP, maybe a quality person, or even an administrative person that may help with data entry. It's always good to have that person into the system. So you just go in and add them, and then they will get an invitation to apply for SAMS access. You'd only have, it says, you can have 2 people that are users or administrators, but there's only 1 facility administrator that has the ability to do everything. There's administrator rights. So the question here is about 2 facility administrators and just clarifying the difference there. So there's 1 facility administrator, but you can have other people with administrator rights, which would give them the ability to add different things that you're reporting into the system. So all of my users at the state have have administrator rights so that they can do what they need to do in the system. So this is what the screen looks like, those little red asterisks. Get used to looking for the little red asterisks when you go into NHSN, because those are the required fields. If it's not, doesn't have an asterisk on it, you can enter if you want to, but you're not required to. So if you're adding a new user, you're going to do the user ID, the first name, last name, a phone number, and an email address, and that's enough to get it started. So it's a pretty easy process. So how information is shared. In Iowa, we have a lot of group functions. That's how IDPH, and I know that the HIN gets access to data through the group function. CDC obviously gets it, and then they share it directly with CMS. But we use a group system. There's a rights template, and I'm going to show you a little bit, I think, on this. On where you go in for that. But so when I want to get access to certain types of data, I can go into the rights template and I can say, okay, I now need to get access to ventilator-associated events, which at this point I don't have access to. But if I decided that I needed that, I would go in, I would modify my rights template. You guys would receive notice that it has been modified, and you can go in and change or accept that. Now, here is something that I'm going to caution you on. If you get a new rights template from either IDPH or IHC, I would encourage you, if at all possible, to accept it as is. What we find sometimes is that people will go in and say, well, I'm not reporting on this, so I'm going to mark that as a not applicable. That you can do that, I mean, if you choose to, but it's very difficult to get that not applicable off the system, and what you sometimes have to do is to leave the group and go back in to get it to work right. So if, say, you decided that, though, I'm not reporting CLABSI, so I don't need to do that, so you mark the NA, and then you start getting a lot of lines in and you wind up reporting CLABSI, it's important that you leave that and accept as is, unless you have some real objection to a facility or to a group having access to your data. And then I would question you, if you really are concerned about somebody having access, why are you in their group? But I would really encourage you to accept them as they are sent out to you. Only the facility administrator can join groups and accept the rights template. And so if there are any of you that aren't a part of the IDPH group or the IHC group, this is your opportunity to do that. I put my group ID in there. You would also need the group password, but when I tried to type that in, it went in as coded, so it wasn't going to be helpful, but it's IDPH-HAI. So L in lowercase for the IDPH group. So you would just go in, type in the group ID, type in the password, and join the group, and then confer rights. And you can see what types of things we ask for when you're in that confer rights template. I haven't heard any concerns recently from those of you that have looked at the rights template. The information that's being requested, if it's on there and you're not reporting it, just leave it, and nobody is going to force you into reporting it. I wanted to spend just a couple of minutes here talking to you about, because this is probably the most common question that I get when I'm either answering phone calls or if I go out with a group, is what is required to be reporting to NHSN? And when you're, especially for those of you that are in small facilities and wearing multiple hats, there's a concern about committing and what's really indicated. And so I wanted to spend just a couple of minutes here to try to walk you through how you would normally do that. And I do have some examples that in these slides that you can have, and to see how, if you are reporting everything that's being asked of you, how to set up that rights template. But this is one of the things that, especially from new IPs, I'll get from, okay, how do I do this? Do I have to report on SSIs? What kind of things am I doing? So my first tip off is this is not a decision that you have to make on your own. Talk to your quality staff, talk to your facility leadership, try to determine where your priorities are. If you don't do a certain type of surgery, it doesn't make any sense to put it on your reporting plan. But I know that a lot of facilities are starting to do orthopedic procedures, and maybe you haven't been reporting on that. But if it's a new service that you're starting up, that would be a really good thing to consider reporting into NHSN. Even if you don't report it, you're going to want to monitor that data, and it really doesn't take that long to report some of this. So working through what the expectations of your leadership is for you to be reporting, what kind of services are you providing at your facility. I know that some of you don't do a lot of central line insertion, but if you're caring for PICC lines, that would still fall under the CLABSI, so I would encourage you to consider reporting onto CLABSIs. Probably the most important thing on here is to figure out what kind of information do you have and how are you going to get the information. When I go out to do some training with somebody who's brand new into the system, we even sometimes have to figure out, where do you get your patient days? How do you know how many central lines you have in a month? And I know a lot of you are doing that manually, but you've got to be able to figure out where that information is going to come from and if it's feasible for you to report that. And you'll find that most of this is not that difficult, especially as we're moving into EMRs. It is becoming easier to retain some of and to obtain some of this information. So this is the monthly reporting plan. This has to be set up for every single month that you're going to report. So if you're going to start reporting on CLABSIs in January, then you need to set this up for January 2018. You've got your locations. So when you go into the locations, anything that you have mapped into your system is going to show up there. So if it's your med-surg, you would select that, mark your CLABSI and CODI if that's what you're reporting, and move on. So if this is an example of what it would look like for this facility, has 3 units that they're doing CLABSI and CODI, and 1 that's a surgical ICU that they're doing ventilator-associated events. This is what the procedure-associated module reporting plan can look like. There again, you may, in your facility, not need to be reporting on each one of those things. Find out from your surgery department what they really do. If you're not doing hips and knees, then obviously you're not going to put that on your reporting plan. If you don't do colons, don't put those on. But usually there is a type of procedure that you can put into this system and get that loaded on. In most cases, these are going to be for inpatient procedures. You do have the ability, if you would like, to report outpatient, but in most cases it's inpatient. This only has 1 line when you go into it. If you click that add a row, you can add as many different types of procedures as you want. C.diff and excuse me, MRSA lab ID events, for some reason, has been a challenge for us in Iowa to get these reporting plans set up and our data entered correctly. So I am going to spend just a little bit of time on lab ID events. So when you're doing a lab ID event, CDC and CMS expect you to do for your facility, so it's a facility-wide in, your emergency room, and then if you have a separate OBS unit, then that would get entered as a separate unit too. Now, if you don't have an OBS unit, and I know a lot of you do not, you don't need to have that on there, and it's only going to show up if you have that unit mapped into your system. So in most cases, it's going to be facility-wide in an emergency room. It's lab ID events for C. diff. It's blood specimens only for MRSA bacteremia, and you can just mark those as you need to, and you can always add lines as you go with that. Here is again for the MRSA, and note that it's saying lab ID event blood specimens only. I see some facilities that will mark all specimens, and then they try to do anybody who comes in with any MRSA at all in their wounds, and that gets to be a little annoying. So I would encourage you just to look at blood specimens, mainly because that's what most other places are doing, and if you're wanting to use this to compare and to have some sort of a benchmark, you're going to want to do the same thing that other facilities are doing. So once you get your reporting plan set up, then you need to start looking at entering your denominator data. Denominator data needs to be entered. It's entered per month. It needs to be entered for each unit that you include on your reporting plan. So if you have a med-surg unit and an ICU, you would need to do denominator data for both of those units. It will also have a separate Lab ID page event for Lab ID events. So it does take a little bit, but it's really not that hard to find. So here's an example of the Lab ID event reporting plan. And you can see here that for this month, it's for February of 2015, I had it set up to report MDROs and C. diff days. This is going to change here in the future. This has created a lot of confusion for facilities, but you'll notice here down here where it says CDI days, that's probably the biggest concern when we do quality checks at our at IDPH, where we run data every quarter before data submission is due. And if I see an issue, sometimes I will see 0 under the CDI days and CDI admissions, or maybe 1. Because people will think that that's the number of patient days or number of admissions of patients with C. diff. That's not what that number is supposed to be. So I think I have my next slide here to give an example. So on this slide, you can see how that would be filled out correctly. For this facility, for that month, there's 398 patient days and 67 total facility admissions. Now, when I take those out for assuming that maybe this facility has a NICU or well baby, I'm going to take that number, the patient day number, and the admissions from the nursery off of that. So I took that down to 376 for the CDI days and 63 for the admissions. It has nothing to do with the number of patients with C. diff. So they are changing the wording on that. I don't know what it's going to look like yet. I haven't seen how they're modifying it, but that will be changing probably with one of the next updates. This is what a device use reporting plan or summary data is going to look like. There again, I have indicated I'm doing central lines or CLABSIs on this. And it is, so those little red marks are telling me that for that month, all I was going to report on was CLABSI. So I need my total patient days and my central line days. If I would have said for that reporting plan I was going to do CODIs, it would also have a red asterisk by the urinary catheter days. If you go in there and you don't have anything to report for those, for that month, if you don't have any infections to report, that over where it says the report no events under CLABSI and CODI, you would just mark the boxes there, and then that's all you have to do for the month. Do we have questions that we need to? Yeah, let's look. So we've got a couple of questions we're gonna,
just read it for them.
So when entering event, what is recommended for creating the, that's a really good question. So the question is the ID number for the patient, and I think I have some events examples or down here, but the event for the patient ID, sorry about that, is usually the medical record number, because you want something that's going to stay consistent throughout each hospitalization. So a lot of times the financial number changes with each admission. So you want to make sure that you're going to use something that will stay the same. So especially in a case where somebody has surgery and they come back in with an infection, you want that medical record number to match up. So they recommend matching up or using a medical record number. I have somebody else that says we have a FAC-wide out set up for MDRO. Do we need to report those? No, we're really looking at inpatients or people that are in your facility. So that's where you catch some of the outpatients by using an OBS unit and an ED, but if they're sent in from a clinic, there's no need to report those. You're only going to want to report your ED patients and your FAC-wide in, is what most places are going to do. And the other question is on the, if we can go back to the, it didn't show on here, but the HH and GG at the far left, That's hand hygiene and gloves. So some of you can use NHSN to report. So the question is, what does the H&H and GG at the far left mean? So if you're doing hand hygiene monitoring and recording that into this system, you can. I don't know anybody at this point who's been doing that. And then glove use.
So Nancy, a couple other things we have in our chat box include, is this going to be taped? Yes, we are currently recording this session, so we will be able to share that outward with our participants as well as our other hen hospitals. The next question is appreciating that the CDI patient days is clarified and wondering if you can walk us through a lab ID C. diff event. So
I will be happy. In fact, that's one of the areas. I don't know why I'm not moving forward. Trying to advance my slides, it's not advancing. So when you're adding an event, so that was a perfect lead into my next slide here. So thank you for asking that question. So I wanted to talk a little bit about reporting a lab ID event. The first thing is to report, you report all positive tests obtained on inpatients, regardless of whether or not they come in with a positive test. So if it's an inpatient, an observation, or an ED, you would report that. Now, I'm going to qualify inpatient because you'll see in my next bullet on this that the FAC-WIDE-IN includes OBS patients on an inpatient location. So if they're in a bed on your med-surg area and they have a positive C. diff test, you report that. The system then looks at your admission date and the date of the test that is obtained, and it determines whether or not it's a facility acquired or if it's a community acquired based on those two admissions. So if the patient is in the emergency room or on an OBS unit, you would assign it to that, even if they wind up getting admitted down the road. When you go in, and I think I have another screen here that it can show that it is, you're going to select event type is going to be a lab ID event, and then the organism is C. diff. I do on occasion hear people, and I think if we go forward here, and I have another question, but I'm going to cover my thought here first. So under that event type, I've had people choose GI, and it won't show up as a lab ID event, so it won't get recorded properly if you do that. So make sure that you choose the lab ID event under event type there. Here again, this is where you're going to start entering an event, and you can see that very few things are required on this slide. There's a patient ID, so your medical record number, your gender, your date of birth is all of that for the patient information that is required. I'm going to tell you, if you want, you can record as much information on this as you want. You can put a patient name, you can do the ethnicity and race, Medicare numbers, those types of things are available that you can enter at any time. If you do that, please feel comfortable knowing that when we set up our rights template, we're not asking for patient-specific information. So even if you put a patient name in there, nobody else can see that. So you're not changing anything, or you're not risking any patient confidentiality by doing that. So I have a question here to CDI admission, going back to that slide on the summary data. So it's not patients that are admitted with C. diff, it is the number of patients admitted to your facility minus any newborn nursery, or if you have a separate rehab unit with a different CCN, then those numbers would be included. So if you're not delivering babies, then your admissions and your CDI admission numbers would be the same. If you do admit babies, then the number of admissions to your nursery would be deleted off of that number. And so if that doesn't answer, give me a call and I'll be more than happy to help you walk through that. So I want to go ahead. Yeah, thank you. and show you here that this lab ID event for MDRO or CDI, that's where you're going to want to enter it. If you're entering an event for lab ID, you're going to put the date the specimen was collected, the organism type, which is going to be your C. diff. That is where you're going to say that it's a stool specimen, a GI source, the date that they were admitted to the facility, the location. So if it is on your med-surg unit, you would put that, and then the date admitted to the location.
We have a new question.
Is this the date? So I'm not sure if I'm understanding correctly. So it says here, the lab ID event, at event screen, date admitted to the facility. Is this the date admitted to the collecting location? In most cases, it's going to be the same. So if they go up to your med-surg area, that's going to be the date of admission to that area. So if it's collected in the ED, it would still be, it would get admitted, or it would get entered as your med-surg. So I'm not sure if that's answering. So the date admitted to the med-surg. So I think it's almost always going to be the same number. So that's it. If it's in the ED before midnight and collected and not admitted till the next calendar day, which I know that happens a lot, which is the date admitted to the facility, I would use the date in the ED.
Good question. Okay.
Oh, we're working here together. So this is just an example of what a lab ID event would be. In this case, this specimen was collected on 3/1. The date admitted to the facility was 8/22. So this would be a facility onset infection. And you see that that's where I've entered under the specimen body site. That's where I've indicated that it's a digestive system, so a stool specimen. Those questions down at the bottom are very helpful. Has the patient been discharged from your facility in the last 4 weeks, or have they been discharged from another facility in the last 4 weeks? If at all possible, on that bottom one, if they've been discharged from another facility, it's important that you enter that information. It helps to determine whether or not it's healthcare associated but not your facility. There's a question here. We have our swing and transitional care patients included in our med-surg unit. Do you recommend separating? No, I do not, because what that does is it's really a payer source. They're in your unit, and if they're on your med-surg unit, especially as a critical access, we would encourage you to put those numbers all together. The risk factors are the same. And I understand this. The comment goes on to explain that these are longer term, so obviously they have different, especially for COTIs, those types of things, the risk factor changes, but we would still encourage you to report those together. The payer source isn't important to CDC, it's the risks. So they don't really care if it's paid as a swing bed or if it's paid as an inpatient stay. They just want to know what the risks are and how you're preventing those infections. If I don't answer your questions, just feel free to type in another one or call me at any time, because the reason we're doing this is to try to answer as many questions as possible. So I'm doing my best, but if I don't get them answered all the way, just let me know. So the last physical location before they came in was the long-term care. This is important information for CDC to know. And the reason for that is they are doing a lot of focus with long-term care right now. If it was an outpatient, so if it was on the OBS unit, you've got the little red circle there that says it was an outpatient. So on your observation unit or the ED would be the same. So I touched base with this just a little bit. So when you put your date of admission and your date of collection, specimen collection, you can see that NHSN categorizes that either as a community onset, so it happened within those first 3 days, a healthcare facility onset, so it was after day 3 of your admission, so if it was day 4 or after, or a community onset healthcare facility associated, so maybe they were discharged from another facility like a long-term care, a week later they come into your facility, then that would be, it's a community onset, but it is a healthcare associated infection. It just doesn't get attributed to your facility. Adding a device-associated event is, I think it's a little bit more straightforward. You've got a bloodstream infection. And you just put the type of infection, whether or not there was a central line in place, that type of thing, and just go ahead and mark that. Based on the type of event that you're entering there, it will reset the screen and ask you the appropriate questions. Always look for those little red asterisks. That's going to be the tip-off onto what type of field you need to be putting into it. So I've got a couple of questions here. In critical access hospital, we have long-term care, hospice, skilled, inpatient, observational, all in the same department. Would I include all of the above? My answer is yes. You would put all of those in if they're housed on your med-surg area. Now, where I have seen a couple of critical access will have a separate wing that they will put their swing beds. Then in that case, you could set that up and exclude those numbers. But in most cases, I would say that they would all go into one unit. And I don't know if that's the same as what it's different. I can tell from the look on his face that that's different than what they're advising. So do you want to address how you guys would like that?
Well, for us, we are saying if they're on inpatient status. So it's all of those areas then that if they're inpatient status, those are the ones that are counting. Of course, we get the data from NHSN, but I think the key piece here is what do we mean by skilled versus long-term care? So if it's a skilled bed versus long-term care, that's how I'm reading the question, because she's saying if it's long-term care, isn't it considered their home?
We would, and I'm going to tell you that the answer from NHSN would be to include those in.
Okay.
And basically just goes back to that fact that from CDC's perspective, they're still in your bed. You're not counting them for everything, because if they don't have a central line, they're not going to get reported for CLABSIs. Most of the long-term care don't have Foleys. There may be a couple that do, but those are going to be highly unlikely. So here's the caveat that I always encourage: the more you include in your denominator, the better. And I understand that they have the ability, they may be more likely to develop a UTI. It's highly unlikely they're going to really develop a CODI. So you want your denominators to be higher. So I would encourage you to include them if at all possible. Now, if that's going to mess up with the numbers from the HIN, I will bow to them, because a lot of you are reporting this for them. But CDC's position would be if they're on your med-surg unit, you would put them in.
So what I am saying, just to re-clarify, is if it's anybody that's inpatient. So our skilled people in our hospitals, we consider inpatient as well. So I think we're saying the same thing, just a little bit differently. And so if anybody has any confusion or questions, they can reach out. Another question has come in here too, if you want to try to address this one.
We did.
We finished that one, thank you.
And there was also, will you have access to the slides? I am fine with these being shared, so I would hope that they will be available to you. And I also have my contact information in, so if you want me to send these out, or if you have any questions, I just can't tell you enough how much we really want to be helpful at IDPH, and if we can help in any way, please feel free to give us a call.
And just with that note as well, we are actually recording, and so yes, people will be able to listen to this again later. We will post this on our Innovation site, as well as we will place your PowerPoint slides in a PDF form on Innovation as well. And then if people want to see it again, they can always reach out to the consultant or again to you.
So here's a question that says that if it was the same staff caring for the patients on med-surg and swing, it should be combined for data collection. In our facility, it is the same staff. So I think that's a key factor here. If it is going to be, in most cases, the same staff caring for both, they're going to be following the same policies and procedures, using the same device. So in most cases, that will be included in that. So this is not advancing
Okay.
for me.
Probably because I moved. See if we get her to move in. There you go.
And I know I'm going to be kind of rushing through here, but one of my favorite things with NHSN is the alerts that come up. And I know that I'm not having to look at these every time I enter the system. You guys are. But I would encourage you, if at all possible, to use these to your advantage. Because if you have missing summary items, if you click on that where the numbers there are there, the 1 and 13, and it will take you right to where you need to be to enter whatever data is missing. Once you set up your reporting plan, if the month has gone by and there's stuff due in the system, you will get an alert that will tell you that you're missing summary items for this month, and you can go right there. It'll take you to that screen. You don't have to remember what did I enter, where did I go. So just feel free to use these. I personally love it when I go into a facility and there's alerts, because I can just go right in there, click on that. It'll take me right to where we need to be entering data. So they are definitely my friend. I think they need to be your friend. So go ahead and take advantage of those. Now, here's the clicker. This is your data. I think that sometimes you think that you're putting it into the system and it's really, you wonder why you're doing this. It's your data. It's important that you use it. So I wanted to show you a little bit, because I know that there are those of you that haven't been, had the opportunity to really get into the report area. So if you go under the analysis in that blue column, one of the first thing that you're going to come to is generate data sets. I generate data sets almost every time I go into the system, because it will include an opportunity for, it gathers all of the information that has been entered into the system and puts it into a format for you to be able to run reports off of. So generate those data sets as much as you want. If you have multiple users in your facility, you each need to generate data sets, because if I generate data sets, then it doesn't generate the data sets for my coworkers. So just, you'll need to generate data sets, and you'll be able to run reports based off of that. And it will be able to tell you here when the last time that you generated your data sets, which in this case it shows that it was generated in November of 2017. And I have a wonderful little message here from South Dakota, from Jennifer, that if there's any South Dakota hospitals on here, please feel free to reach out to her, which is a great benefit. I'm thrilled to know that you guys have lots of resources. It's important that you know that I know this seems a little overwhelming at times, but you've got a lot of people that are willing to help you. So there's a lot of canned reports into this system, and I just wanted to give you an idea of some of the things that are available. It's divided out according to the different modules, so there's device associated, MDRO modules, the procedure associated, so for your surgical site infections, and also for the larger hospitals that might be on the call, that CMS report is really important for you to run before the data is submitted, because it will show you what CMS is going to get. And so you want to know what's being submitted on your behalf. So make sure that you run those reports. It breaks it down. It puts it into quarters so that you can see exactly what's getting transmitted on. So even under the urinary tract infection, or for the CODIs, there's a lot of different reports available. So I wanted you to be able to see, you can do a bar chart, you can do a rate table, a run chart. There are those types of things. We usually look at the SIR reports, so the standardized infection rate and the standardized utilization ratio for facilities. And even though you're critical access, if for those of you that are critical access hospitals, sometimes I hear that, well, we're too small to generate an SIR. You will have something under the SUR that is going to be usable. So go in there. They now have separated those out, and you can actually get some reports that you can use in your committees and help you monitor where you need to be. I'm really excited that they now have a separate report for the critical access hospitals, and it does, this is an example of a SIR for critical access, and this is the state group that we have for all the critical access in the state. So you can see we're doing pretty well in our critical access, the SIR of 0.192 for the first half of 2018. So that's really good information. So this is the utilization rate, so the catheter utilization rate. Here again, it's for critical access. We're doing better than our SIR is below 1, but we would want that even lower. So remember that one of our focus is to avoid unnecessary catheters. And I know that for those of you that are just getting started here, this may be just enough to wet your whistle. There's some really good NHSN training videos out there. You can have access to videos if you want to do that. If you want a slide presentation, those are out there too. I would encourage you to go in and start and play around. I was one of these people. I did a lot of training before I got access to NHSN, and then I started getting into it, and then it gave me more questions, so I wound up having to get into it. I'm a real visual person. I have to be hands-on. So do the training. Feel free to do them as many times as you need. And so there's the link to the training. There's also a link to the patient safety manual. I print that off every single year when that is updated. I keep a copy at my desk. If I'm going out to a meeting, I frequently stick my manual into my book and take it, because a lot of times I will get questions on, does this meet a criteria? So when you guys call me and say, help me to determine whether or not this is an SSI, I pull that manual out and walk through the definitions with you. That's where you're going to find all of the definitions. So go into that, and I really do encourage you to print it off or to bookmark it so that you can pull it up and look at it whenever you have a case that you're trying to investigate. So I'm kind of winding down here. I didn't know if anybody had any questions at all.
Right. We've been answering those as we've gone along, but please feel free to put something into the chat. If you want to raise your hands, we can unmute you as well. We want to make sure that we're meeting your needs with this webinar, and I know that Nancy's answered many, many questions so far, so very nice.
And I think
here's a note, really good review to Nancy, thanking you for the clarity for today. So thanks.
Thank you for the comment. I really appreciate that. My next slide here, while we're waiting to see if anybody has any additional questions, I wanted to make sure that you have some information on how to get in touch with us if there's anything that we can do. We do have 3 of us. Lisa Vitale, which a lot of you have met over the last few years, is going to start working. She's in the Des Moines area now. You can call her. We will be more than happy to help you. Here's her phone number and her email. Tyra is fairly new with the team. She's been doing this. She's getting pretty good on NHSN, and she's actually done a lot of reporting because she came from an IPPS hospital. So she's got a good background on that and is really knowledgeable. So if there's anything that any of us can do, please feel free to shoot us an email if that works easier for you, or just give us a call.
So I have Tanya Root who would like to speak with us. So Tanya, I've now unmuted you. I see your hands raised.
Yes.
So we're able to hear you.
Okay, hi Nancy. My question, I'm from Franklin General here in Hampton, and I have noticed as a critical access hospital, our NHSN data is not being relayed for our star rating for the HAIs. And I've also sent an email off to Lori Parsons who did forward that on to, let me see here. She forwarded it to Betty Wenford, who's also checking on it. But the information that I've gotten, it says something about we're not an eligible APU hospital or currently closed in the system, and that's through Quality Net. And then another one, it says CARI data submitted to NHSN by hospitals that have completed their annual payment update pledges will be reported to CDC for each hospital. I don't have any idea what an annual payment update pledge is. I'm wanting the data to go there so it's reported through our star rating. Maybe that's not even possible as a critical access hospital.
Okay, Tanya, I'm going to go ahead and mute you, and we'll see if we can answer your questions, at least some of it. It was difficult to understand you.
Yeah, you're kind of breaking up a little bit. So there was a new pledge that was sent out. If you don't have that, I think I can walk you through. It might be easier if we did that over the phone, if you want to give me a call. But there was a pledge that went out, or new agreement with NHSN. So for things to be reported on, that went out to the facility administrators and was supposed to be returned electronically. So we'd be able to walk through and see if that happens at your facility. I don't know if that's part of the problem. I do know that with some of these reports that get submitted on, the reason that things aren't posted is because the numbers are low enough that it gets excluded. I don't know if that's the issue. It'll be interesting to see what Lori says when she gets back to you. I'm wondering if it's partly because the numbers are so low. And that's frustrating because when you don't have any infections, you want to be able to show people, hey, I don't have any infections. But sometimes with really low numbers, certain agencies suppress that data. So I don't know if that's part of it. But if you don't get an answer from Lori, which I know she will try to get back to you as soon as she can figure something out, let me know and we'll see if we can get a response and figure out that. And if you don't know if you signed that agreement, call me and we can try to walk through to find out if it's been completed for your facility.
And then Nancy, we have one last question for you as we close out today. Could you please talk about the thresholds, like meaning the minimum for reporting surgical site infections?
I'm probably going to get in trouble for this one, but that wouldn't be the first time I've been in trouble. You know, this is really one of those areas. I know that IHC has used 10 in a year as a goal, so if you're doing less than that, it has to be at a facility where there's value to you to do it. And I will tell you that that number is pretty low, and you may or may not get any reports that are really helpful with that. But if you decide that you are reporting surgical sites, you do have to enter denominator for each and every one of the procedures that's done, which takes a little bit of time. So I encourage you to maybe pick one type. If you're not sure if you can do it, pick one type of procedure, maybe a higher volume. If you feel like you can add on to it, then to add on as you go and get more comfortable with the system. So I usually try to encourage people to talk to your surgery, find a higher risk procedure, and usually try to stay with one of those 4. Because if you start entering stuff that nobody else is entering, you won't have anything to compare. So if your goal is to get some data to be able to compare, choose like hysterectomies or something that you have a higher volume and start reporting that. And kind of see how it goes from there. I know that 10 has been given out there if it's 10 in a year, but I will go on record as saying I think that that's still it may still be a challenge for you to get usable stuff, but if you are participating and agree to do it, then that's what they're saying.
Well, thank you so much, Nancy, for joining us today and providing so much information about NHSN. We are at the top of the hour again, and so we will be closing out. Again, the contact information for Nancy, Lisa, and Tyra is here on the screen, and we will get these slides posted to Innovation. And always know you can reach out to the Department of Health as noted. Thank you all for joining us today. Have a great, great week. Thank you.